for sticking with us as we just flew through those updates quickly. Really appreciate it. So, switching gears, what everyone is super excited about is today's topic on pharmacogenetics, a word that is really hard to pronounce, but hopefully I'll get it right. So I'd like to introduce Dan Doherty. So Dan Doherty, clinical trial manager, has been with Genelex since 2006. He works closely with Genelex's pharmacists, which has allowed him an intimate understanding of pharmacogenetics. He's had the unique opportunity to speak near daily with patients and heard the impact polypharmacy and pharmacogenetic testing has had on their quality of lives. He previously worked on-site managing the daily routine for residents in a nonprofit group home, seeing both the positive and negative impacts of medication management on a daily basis. So Dan really gets it, and he really is someone who works on behalf of patients, which we really appreciate. And just some information about Genelex, his company, who we are grateful to for loaning us Dan for this hour to talk. So Genelex is based out of Seattle, Washington, and they are a CLIA licensed CAP certified lab, which has been providing genetic testing services since 1987. In 2000, Genelex began providing pharmacogenetic testing and created UScript, a clinical decision support tool. When combined with Genelex's pharmacogenetic test results, the system checks for cumulative drug-gene and drug-drug interactions, allowing physicians to navigate their patients' medications management in light of their genetics, medications, supplements, and herbals. That's just sort of a quick overview of Dan and of Genelex. So I'm going to switch over to his presentation, so just bear with me for 1 second. And in the meantime, Dan, are you on?
I am.
Great. Okay. So whenever you're ready.
Okay, great. Thank you for the introduction, and actually you can jump right into the next slide. I'm gonna go through these first few slides quickly until we kind of get to the meat and potatoes. Quick acknowledgement. Thanks, Emily and U.S. Pain Foundation for putting this together today, and also to the Coalition Against Pediatric Pain, who really introduced us to patient communities that we were previously unaware of. You can jump to the next slide here. And just quick disclosure, I work for Genelex, and I'm not a medical professional. I know a lot about pharmacogenetics, but I'm not a physician or pharmacist. So it's very important that you not make any changes to your medications based on this presentation. If you learn something new, you want to make a change with, contact your physician and have a discussion with them before making any changes. You can jump to the next slide. And I'm just going to jump through a couple quick key terms. And some of these we're going to be discussing in more depth, but pharmacogenetics is just medications plus genetics. It's a big word for something that's relatively simple in that sense. Polypharmacy is just like it sounds. It means multiple medications. So a polypharmacy patient is a patient taking multiple meds. Bear with me, I just lost the screen for a second. Oh, I totally lost the screen. Can you still hear me okay?
Yes, we can still hear you. Is it the GoToWebinar screen that's down?
That's odd. Yeah, it just went completely blank. You still have it up on your end?
I do. Is anyone else having problems seeing my screen?
I can see it, Emily. It's Casey.
Okay.
Give me a quick minute, I think. Okay,
Sure.
1 second. Sorry about that. I'll be right back.
No worries. Technology is so wonderful and yet so frustrating.
Okay, here we go. It's back. I think it just went to sleep. Sorry about that, everybody. Okay.
No worries.
Okay.
No problem.
Good. So you'll hear me say ADE as well. It just stands for adverse drug event. And then efficacy is a term you're probably well aware of, the ability to produce a desired or intended result of drug response. And then enzymes we'll be talking about quite a bit. These are molecules or proteins in the body that accelerate or catalyze chemical reactions. So these enzymes are often needed to break down drugs in the body so that they can leave the body in a timely fashion. Okay, and next slide. Allele and phenotype, I'm going to get into those a little bit later, so I'm going to discuss those in detail. So we're going to skip over those for the moment. And then the enzymes we'll be talking about today are chiefly what are called the cytochrome P450 enzymes. And so these are really essential for the breakdown of the majority of drugs on the market, roughly 80% of all meds. And arguably the most important of these enzymes is an enzyme called CYP2D6. It metabolizes roughly 25% of all meds on the market, as well as a lot of commonly prescribed opiates. Next slide. And so learning objectives, the number one today is really understanding what can affect pain medications so you can work with or around them. And this can range from supplements to herbals to genetics. And then we'll go over 3 sections: pharmacogenetics, where it's gene-drug interactions. And then it's important then to understand also the difference between prodrugs and active drugs, especially in pain meds, because they function differently depending on your genetics. And also the role of inhibitors and inducers. And I'll go into those in detail as we go along. You could jump to the next slide. So our best effort to impact drug response, basically compliance, taking the drug as intended according to meal times, according to sleep, but also being aware of other interactions with other sources such as other drugs, supplements, herbals, and then genetics. You can jump to the next slide. And so pharmacogenetics, why is it important? Very simply, your genetics impact how you respond to medication. So knowing how you metabolize drugs allows your physician to choose the most ideal drug for you. Next slide. And again, pharmacogenetics, it really just means big word for medications plus genes. And the key takeaway, if anything today, would be, people do not respond to medication in the same way, and we inherit our response to drugs. So just like folks who have cancer in the family or heart disease in the family, these are things that are inherited. It's genetic, just like your drug response. And next slide. And so these enzymes are present in nearly all living things. So anything from animals to plants to even fungus. And next slide. The significance of these enzymes, they allow for the detoxification of xenobiotics, such as certain drugs and environmental toxins. So these are even things you can breathe in from outside that was not originally in the body. It's a xenobiotic, something outside the body that's being taken in. And these enzymes break those down so that they don't poison the body. Next slide. Now this one looks tough, but bear with me here. So this is kind of a key slide. This is the effect of drug metabolism on excretion. So these enzymes are chiefly made in the liver for the most part. And on the right side, you see what is a normal metabolizer. Basically, you see the drug in green, the left side, the drug in green is able to be metabolized because the individual makes the enzymes to break down the drug. And then the drug leaves the body through urination. On the right side, we have an example of what we would call poor metabolizer, someone who takes the drug in blue there, but the drug cannot be broken down by the body. And because of that, it cannot leave the body as normal. And instead, it ends up staying in the body, essentially loitering in a way that is not intended. You could jump to the next slide. And so about roughly 80% of all meds on the market are processed by genetic-specific enzymes. And over 90% of the population have variations of these enzymes in their body. You could jump to the next slide. And to give you an idea of what that could look like, you could have a patient group with the same diagnosis and same prescription having different responses. For some, the drug could be beneficial. For some, it could actually potentially be toxic. For others, it might have very little efficacy and not seem to work. And next slide. And so alleles are an important part to understand about this. This is how this is passed down. An allele is typically you'll receive one from your mother and one from your father, and this works for pretty much all genes this way. But it also happens to work, obviously with pharmacogenetics. And this is how we identify someone's test results by determining what allele they have. We can then determine if they're what's called their phenotype, which determines, how their drug response. You can jump to the next slide. And in a test result, this is what the alleles look like, and the alleles determine your genotype. So it's the circled part there would be a star with a number, and that would be from either your mother or father, and then a slash and another star with a number. And based on that data, we can make a conclusion about the phenotype. And next slide. So the phenotypes are the thing you really discuss with your doctor. You don't really talk about the genotype or the alleles. That's more on the kind of lab end of things. The phenotype is, where you're coming to your doctor and you're saying, hey, I'm a poor metabolizer, I'm a normal metabolizer, or ultra rapid. And phenotype just means to show type, and it's a standard term in genetics. You can jump to the next slide. And this is all measurable. Phenotypes, we can look at someone's blood levels of a drug based on their phenotype and see, for example, the one in gray here, for someone who's a poor metabolizer, if they were to take nortriptyline, their drug level would really spike. They would get, roughly 2 to 3 times the expected amount of exposure to the drug immediately, and then it would stay in their body for, instead of, most drugs are made to be in the body for roughly 24 hours or so. But for a poor metabolizer, the drug can stay in the body at very high levels for 3 days. And for ultra-rapid metabolizers, it's the opposite. The drug level will never really reach the expected efficacy. It'll leave the body very quickly. You can jump to the next slide here. And so I'm going to go through kind of what each of these phenotypes mean. And this is what you would have in your lab report, normal metabolizer, poor metabolizer. So normal metabolizer has 2 functioning alleles, and they can take meds as recommended by standard FDA dose. But they can still have allergies or side effects with meds or other medical conditions that affect how they respond to meds as well. But if you're deemed a normal metabolizer, we know as far as your body's ability to produce these enzymes, you can clear the drug from the body in a standard fashion. And next slide. The intermediate metabolizer has 1 functioning allele and 1 non-functioning allele. So they make less of the enzyme than a normal metabolizer. So for active drugs, I'm going to get into active drugs and prodrugs in a little while, but for active drugs, they typically need a decrease in dose. For prodrugs, they might need an increase of dose. And next slide. And then poor metabolizers, these are really the folks we worry the most about. They have no functioning alleles. It means they make little to none of the enzyme. So if they take an active drug and continue taking it daily, there's a risk of toxicity. The drug level can increase significantly. It could potentially, end up in the ER or something of that nature. For prodrugs, though, it's the opposite. So a lot of opiate pain drugs are prodrugs, and it would actually create a lack of efficacy. If you can't metabolize the drug, then you don't get the active metabolite of the drug in the bloodstream. And I'll go over what that looks like a little bit later. Next slide. And then ultra-rapid metabolizers are really just the opposite of poor metabolizers. They have more than 2 functioning alleles, and they make more of the enzyme than a normal metabolizer. So for active drugs, they would have a lack of efficacy where the drug wouldn't seem to be working for them. But for prodrugs, then it could be the opposite. They could actually have a risk of toxicity because the active metabolite would hit the bloodstream much faster and harder than anticipated. Next slide. And so a single person can have different combinations of these results. So you could be a poor metabolizer for one enzyme and respond very differently to a drug because of that. But you could also be a normal metabolizer for another enzyme and have no problem with a different drug class. So it can, you can have an individual where it can be a little bit of a roller coaster with meds depending on their phenotype test results. Next slide. And so this is probably a good one to take a screenshot of if you have the ability on your computer. This shows the kind of commonly prescribed pain meds and what enzymes they use. So 2D6 handles a lot of commonly prescribed opiates. 2C9 handles a lot of NSAIDs like ibuprofen and naproxen. And then 2B6 handles some really strong pain meds, ketamine, methadone, Demerol as well. So these are in the pain space, it's good to know what your results are for these enzymes so you can kind of manage these meds if faced with taking them. The next slide. So roughly 60% of physicians from study data say they're familiar with and comfortable with pharmacogenetics, which is good. Not too many years ago, it was only 10%. So pharmacogenetics is making headway. Physicians are more familiar. But if you happen to bump into a physician who's not familiar with it, it's important to approach them in a way that is non-threatening, especially if they're not familiar with it. So usually the way that could look is, hey, doctor, as you know, I've had a history of poor response to medications that we've yet to find a diagnosis for. You also know that drug metabolism is affected by genetics. I have a testing kit from a lab I trust to perform pharmacogenetic testing. Do you think this is something we should consider together? So wording it that way is really key. You don't want to go to the doctor and say, I have this thing and this is absolutely going to fix my problems with drugs. Because we don't know that. We don't know till we get your test results. So it's really good to kind of make sure that the doctor's part of the process and that they keep that control, but that you also kind of line them up so they understand that, this is something I've been struggling with. We haven't figured out why. Why don't we do this together? And next slide. Sample collection's really essential. It's just mouth swabs these days. You don't have to have a blood test for DNA. And the swabs are non-allergenic and easy to do. So you can actually do the test yourself at home. The doctor has to sign off on the testing, but that's it. The test itself, you can order online and do it at home. And next slide. And this is what, at least from our lab, what test results look like in part. At Genelex, we do things a little bit different where we hire pharmacists to review your test results against your current medication list. And then they come back with suggestions for changes. And the importance of this is that we look at a patient's entire medications, supplements, and herbals, because there's a lot of potential for interaction between those, which I'll get into shortly here. And so when we type up a report, the pharmacist makes suggestions for different meds, if appropriate, in light of all the other things you're taking, to make sure that we're not introducing any new drug interactions or interactions with any supplements or herbals you're taking. And the nice thing about this report is if the physician's not familiar with pharmacogenetics, they don't need to be. They don't need to understand pharmacogenetics. They just need to read this report, which gives them very specific suggestions for changes. Next slide. And then this is another good screenshot to take. These are free online gene drug tables. And Indiana University, for example, also includes a list of inducers and inhibitors. So without having to even get a test done, you can look up your meds and check if anything you're taking is currently inhibiting any of these enzymes. So I'm going to show you more of that in a little bit. Next slide. And just kind of to wrap up with the pharmacogenetic portion of this talk, keep in mind that pharmacogenetics is just a piece of the puzzle. There are many other things that can affect how you respond to drugs, such as medical conditions that may or may not be diagnosed. You might have something that is kind of flying under the radar, that is more rare, that might explain why you're responding to drugs differently. So, that said, this testing also can save lives for the people who are poor metabolizers and ultra-rapid metabolizers. It can be incredibly powerful in helping them manage their meds more safely. But I just want to give perspective that pharmacogenetics, as important as it is, it's not always the answer for every single patient. So kind of keep that perspective. Next slide. So now we're going to get into prodrugs versus active drugs. And normally I don't talk about this necessarily, except in the case of pain meds, because it turns out a lot of commonly prescribed opiates are prodrugs, and that's why it's important to understand them. And your metabolism, your drug metabolism, your pharmacogenetic test results can impact how you respond to these two classes of drugs. Next slide. So all drugs are either prodrugs or active drugs, and sometimes somewhere in between. Active drugs begin working in your body as soon as they're taken. So NSAIDs, for example, like ibuprofen, as soon as you take it, it begins working in the body. Prodrugs, unlike active drugs, they must first be metabolized by the body before they work as intended. So codeine would be an example of that. Codeine is the what's called the parent, and then there's the active metabolite of codeine, which is morphine. And next slide. And you can kind of see what this looks like. So imagine with an active drug here, the one in green, it begins working in the body immediately. It's metabolized and ready to be removed from the body. But a prodrug like codeine will really not be as effective as intended until it's metabolized by the body, at which point the active metabolite is released into the body and then ultimately leaves the body. So it's important to understand the difference between those two, because depending on your phenotype, your test results, you could respond differently to an active drug versus a prodrug. Next slide. And so then this is another good screenshot, just things to be aware of. So the prodrugs are on the left-hand side here. Hydrocodone somewhere in between. And I've heard pharmacists argue about which drugs are prodrugs and which are not. And so it's, I kind of got some backup on here from one of our pharmacists, and I feel like this is a pretty accurate list. And then active drugs here under the blue on the left, and those again are drugs that will begin working in the body immediately. And next slide. And then this is kind of the last of these three sections, inhibitors and inducers. This is really important because inhibitors and inducers can affect the enzyme levels in your body and potentially interfere with medication response. And we know this is a problem because when we receive patient medication lists with their swabs for testing, sometimes we can just eyeball the medication list and see that there are drug interactions occurring that none of their pharmacists or none of their physicians or even their pharmacists were aware of. And again, this is something that kind of tends to fly under the radar and can happen very easily. And you can be a normal metabolizer, but then take something that stops your body from making the enzyme while you're taking it that can then create an interaction. And I'll kind of walk through what that looks like here in the next slide. So inhibitors, these are probably the ones to worry about the most of these two classes. So inhibitors can be in the form of drugs, herbals, food, and even breathed-in chemicals. That's more rare, but it's true. Inhibitors compete with other drugs for a particular enzyme, thus affecting the optimal level of metabolization of the substrate drug, which in many cases can affect the individual's response to that particular medication, such as making it ineffective or spiking the drug level too, depending on the case. And next slide. So this is what it can look like. You could have you've kind of seen this slide before. We can have a normal metabolizer on the left side here, where they take the drug at normal dose, and the drug is metabolized and leaves the body as normal. But you could also have a normal metabolizer taking an inhibitor on the right side in blue, and the enzyme inhibited by the other the enzyme is basically inhibited, and we call that phenoconverting then the patient to a poor metabolizer. And now the drug cannot leave their body as normal because they're taking an inhibitor that is keeping the drug from being processed as normal. And next slide. So the nice thing is Indiana University has a list of what meds use what enzymes, and they also have a list of inhibitors. And as you can see on here, there's a lot of commonly prescribed psychiatric meds that will inhibit 2D6, which a lot of pain meds use for their metabolization. So this is a problem. You have someone who is dealing with chronic pain and then maybe taking an antidepressant to help with dealing with that pain. And then sometimes, depending on the antidepressant, it can potentially interfere with the working of the pain drug. And not a lot of psychiatrists are familiar with this effect. Maybe we're actually at a conference today for the psychiatric conference, and maybe half of the psychiatrists I talk to are familiar with this. So you really kind of want to double check their homework and go to the website. It's free to use their website the link is there, and just kind of double check to make sure that you're not taking any meds that are using an enzyme where you're taking additional meds that are potentially inhibiting that. The next slide here. And so here's some of those that are really the ones that keep popping up. The inhibitors we kind of worry the most about: Prozac, Wellbutrin, Cymbalta, Paxil. These are commonly prescribed antidepressants, all of which inhibit the 2D6 enzyme. And again, 2D6 is responsible for roughly 25% of metabolization for all drugs. A lot of pain drugs, but also cardiology, even cough medicines, all sorts of different things. Another one to watch out for is rhodiola rosea. A lot of nutritionists will talk about this even on television, but they don't give any warnings that that it can interfere with the 2D6 enzyme. So it's one to just watch out for. And then turmeric inhibits some other enzymes, 2C19, 2C9, which NSAIDs use, and 3A4, which fentanyl uses. So you just kind of want to be aware that there's even certain foods or supplements you can take, and certainly not all of them, but there are definitely a couple handfuls of them that can potentially interfere with meds you're taking. And again, these are, you don't need a test for this. This is just drug interactions at the enzyme level. And we know that these are happening to hundreds, if not thousands, of people every single day across the world who are taking multiple meds. The next slide. And then inducers are just the opposite of inhibitors. An inducer is going to make your body make more of the enzyme instead of less. So, for example, St. John's wort is an herbal that some folks will take for depression, and it induces the enzyme called 3A4, which fentanyl uses. So if you were to take St. John's wort with fentanyl, your body would make more of the 3A4 enzyme because of the St. John's wort inducing it, and then the fentanyl would have less efficacy, get less pain relief from the fentanyl from that. And again, the Indiana University has a list of these inducers on there, so you can go to the website and look this up and see if you're taking any of those drugs, and then if so, go back to your doctor and talk about the potential for a change. The next slide. And then we're almost done here. So the big picture here, where we combine pharmacogenetic test results with the knowledge of inhibitors, inducers, and the difference between prodrugs and active drugs, you can get a better understanding of how to work with and around these medications for better outcomes. The next slide. And the way we know this is we have study data that tells us this. When we take our Genelex reports with the UScript clinical decision support tool, which is basically a database of every drug, supplement, and herbal that's out there, we can reduce, one study we had done, patients tested with our lab versus not tested. It was a random controlled trial, so the physicians chose the patients, not the lab. We had, for the patients tested with Genelex, where the physician implemented our results, we reduced readmissions to the hospital by 52%. We reduced emergency room visits by 42%. And this is just within 60 days, and figured that estimated cost savings of $4,000 to the insurance or to the hospital system or to the patient based on that. And this is a published study in the Public Library of Science. This was published about 2 years ago, February. And next slide. And that's everything. And a quick note too, on our website, if you're interested in learning more, or you want to look into pharmacogenetic testing with us, you can go directly to the website and order kits, or find study data there or more materials. We have a lot of information on the website.
Awesome. Thank you so much, Dan. That was very interesting, and definitely a lot of information to digest. So we'll probably take questions for about 10 minutes. And I just want to remind people again that we can't really answer, very specific questions about your medical situation. But if you have any sort of general questions about how testing works and things to look out for, or about how the science works, that would be definitely welcome. So let's see if we have any questions here. I have gotten a couple questions about whether a PDF of Dan's presentation will be available, and we can definitely, if it's okay with Dan, we can definitely share it on our website. Would that be okay with you?
Yeah,
Great.
absolutely.
Okay.
Yeah.
Okay. We also have gotten a couple thank yous for all the information. And then we do have a couple questions about the cost of testing and whether it is covered by insurance. Would you be able to speak to that?
You bet. Yeah. Unfortunately, insurance is really spotty with this. So for the moment, Medicare and Medicaid don't cover it, though we're in talks with Medicare, in fact, 3 weeks from now, so we might see that change. But for the moment, it's mostly cash pay. It's $379 for the test. And then that includes the consultation with John, our pharmacist, to review your test results and answer any questions you have. And the nice thing is any of your physicians can also call and speak to our pharmacists at any time. And then your physician receives access to our gene drug database UScript for the period of a year where they can go and check for any medication interactions as well.
Awesome. And someone else asked about turmeric, and mentioned that a lot of nutritionists recommend turmeric as a good anti-inflammatory treatment for pain. Is this, in light of what you talked about, is this probably, should this be taken with a grain of salt, or is it just they shouldn't be suggesting?
This is it's a great question. So the trick with turmeric is really just to make sure that you're not taking, if you're going to be taking turmeric, like in high doses especially, you want to make sure that you're not taking other medications that turmeric inhibits, where it inhibits the enzyme. And if you go to that University of Indiana website, it lists, turmeric and what enzymes it inhibits, and then you can check what drugs use that enzyme and see if you're taking any of those drugs. Now, if so, don't make any changes. Go back to your physician first, or then your nutritionist. You don't want to make any stark changes because they may have already accounted for that. They may already be aware of that and be dosing accordingly for you. So I definitely, it's not to say turmeric is bad by any means. The concern is just that if you're taking other meds that use enzymes it inhibits, then it could potentially affect those drug levels.
Okay. Another question is, can it help with interactions to space out your medications and your supplements? Can that help alleviate interactions, or if you have an interaction, it will probably happen?
Depending on the drug, and that question really would fall under a pharmacist, but that's a really good idea if we've seen that happen before in my own family, where someone was taking meds that were really supposed to be spaced out and was having reactions, and they talked to a pharmacist, and the pharmacist just said, "Oh, you just need to time these better," and gave them the correct timing for it, and that alleviated the problem completely. So if you're concerned about that, it's a good conversation to have with your pharmacist. And if you can, try to go to a owner-operator pharmacist or pharmacy. Try not to go to a chain because the chains are like, burger places, and they just kind of tear through people, and they don't really spend as much time with patients. So if you can go to a small pharmacy that's not a chain, you'll have a much better opportunity to speak at length with the pharmacist, and they typically in the smaller businesses will spend more time with patients as well.
Okay, thanks. Another question is, does the testing take into consideration the dosage of the medication and supplements? So does that affect the outcome?
Typically, it depends on the drug, but the test results will, because depending on the results, our pharmacist might suggest either changing the dose or just switching to an alternative medication altogether, depending on the test result.
Okay. And a couple people are asking about, they say that they've had pharmacogenetic testing done previously, but they're wondering if it's possible to have Genelex review current medications and like review their past testing?
Ooh, that's a good question. Not really, because part of the problem with that, especially if it was, well, I'm not going to name names of places, but there have been cases where different labs came up with different phenotypes from our lab, and we retest and find that that our lab was accurate, the other one was not, or at least the interpretation of the phenotype was off. So we're not comfortable, doing that at this moment. That said, we're creating a system that will allow us to do that in the near future. I'm hoping the next year or so. So we might have something available like that down the road.
Okay. Another couple of questions and we'll wrap up. But one question is, do factors like ethnicity and gender affect pharmacogenetics?
Good question. Not gender that I'm aware of, but ethnicity definitely does. So I could give examples, but absolutely, yeah, you could have one population that's much more likely to have poor metabolizers than another based on ethnicity.
Okay. And then I know you might be hesitant to answer this question, but we sort of talked about antidepressants and some pain medications having interactions, some supplements. Are there any other like categories of medications that you would like maybe flag for people? Not naming like necessarily an exact medication, but like what should people keep an eye out for or be a little wary of, or maybe ask their doctor about? Are there any like broad combinations that they should be watchful of?
Yeah, that's a good question. The one slide I had with the 4 antidepressants there, those are really kind of the biggest offenders that we see on a regular basis. But you're absolutely right. There are definitely numerous other meds that can inhibit these enzymes, and the Indiana University website has that list, so you can go on there and see all of them. And so that would be a good place to go to check for that.
And then just one more question here. Do you know, like, to what extent can pharmacogenetics be affected by the specific disease in question? So the example they gave was pancreatitis.
Yeah, one of those words was fuzzy and I didn't hear that. Could you repeat that?
Oh, sure. Sorry. So the question was, to what extent is pharmacogenetics affected by the specific disease that is causing the pain? And the example they gave was pancreatitis. I don't know if that's too specific of a question for you to answer.
I think I know where they're going with it. So we did an informal study of patients that had chronic acute conditions where there was a lot of issues with adverse drug reactions. And early on, the physicians we were working with were thinking that, these patients might be more prone to having their enzymes functioning differently than normal. But when we tested roughly 200 of these patients, and when we kind of put them up against the typical population we test, we found that the numbers pretty much matched. So I don't think there's been any proper studies along these lines, but I feel like it's probably relatively safe to say that it's not other medical conditions that affect these enzyme levels. It's really just your genetics and how it's passed down. So your ethnicity and your parents' genetics are going to play the largest role in your baseline genetic level to make these enzymes. But other medical conditions can definitely affect medications. So it's a slippery slope because there's so many things that can affect how meds work in your body. Pharmacogenetics is a big one, but it's not the only one.
Gotcha. And then another question we have is, can you briefly explain inhibitors again and how are pain meds affected by them?
Sure. Yeah. So a good example would be, let's use codeine for an example, which is a prodrug. And let's say you had someone who is a quote, normal metabolizers. They make a typical amount of the 2D6 enzyme, and codeine needs 2D6 to work in the body. But if the patient was taking an inhibitor, so for example, let's say they were taking Wellbutrin, which is an antidepressant that strongly inhibits the 2D6 enzyme. So if they were taking Wellbutrin and codeine at the same time, the Wellbutrin would stop their body from making the 2D6 enzyme for the most part. And then if they were to take codeine, they would not be able to convert the codeine to its active metabolite morphine and would get very little pain relief from the codeine.
Great, thank you. And then, okay, one last question for real. They keep coming in slowly. So we'll do one last question, then we'll wrap up. And I thought this was an interesting question. Are there any ethnic subcultures known for being more susceptible to pharmacogenetic issues, such as Ashkenazi Jews? And I probably butchered their pronunciation of that.
No, you got it.
I did. Okay,
yes,
cool.
yeah, and they're absolutely right. Yeah. So again, ethnicity definitely plays a role in this. So for example, the 2C19 enzyme, which not many pain meds use that, but some antidepressants and Plavix, which is given its stenting. Hispanics, like only 2%, like Hispanics are in the best position for that. Only 2% are poor metabolizers. Caucasians, it's 4% are poor metabolizers. But then for East Asian, Pacific Islanders, and Africans, it's much higher. I think it's around 17% or so. So ethnicity can impact your likelihood of what your phenotype ultimately could be.
Excellent. That's super interesting. Okay, so we have some other questions, but they're a little more specific about certain drugs and such. So what I would encourage folks to do if they have a question that's really specific to their conditions and their medications is to try emailing Dan directly, and he can try to help you out. So thank you all so much for participating today, and thank you especially to Dan. We really appreciate your time. That was, I think, super informative, and we've gotten a lot of thank yous from folks in addition to their excellent questions. So we really appreciate your time.
You bet. Thank you.
And just one last thing quickly, I'm going to fly through